Okay, thank you, Zubin, very much, and thank you for the opportunity to present on this topic that's near and dear to my heart. When I actually think of the first question that I've posed to you here, where have we been? I can't help but think of my career journey, as I actually have focused my 12 years on faculty here at Duke to the study of the Implantable Cardioverter Defibrillator. I don't have any potential conflicts of interest with industry. My research is being funded by the government. And I'm sure everybody here knows that the Implantable Cardioverter Defibrillator has been shown to improve the survival of different patient populations, ranging from survivors of cardiac arrest to patients with sustained ventricular tachycardia with hemodynamic compromise and no reversible causes, to patients who have significant systolic dysfunction. And on this slide, I'm showing you the main results of the two pivotal randomized clinical trials of primary prevention ICDs. Here's the MADE-2 trial that was published in 2002 that showed a 31% relative risk reduction in all-cause mortality with an ICD. And then the SCADHAF trial that has been the largest and the longest randomized clinical trial of primary prevention ICDs, and that showed, after a median follow-up of 45 months, a 23% relative risk reduction in all-cause mortality with an ICD compared with placebo. So I still remember vividly how excited I was when I first joined the faculty about the endless opportunities in research related to ICDs. Gaps in knowledge about ICDs at that time are listed here. How is this therapy being utilized in clinical practice? Do the results of the main randomized clinical trials of primary prevention ICDs apply to patients seen in routine clinical practice? Is the benefit of ICD therapy that was observed in the randomized clinical trials durable beyond the limited follow-up of those clinical trials? And how do we optimize the safety of ICDs and leads? Can we improve risk stratification of patients for sudden cardiac death beyond the ejection fraction? What is the cost effectiveness of ICD therapy and in different patient populations? How do shocks affect survival and quality of life? How do we reduce the risk of inappropriate ICD shocks? And early on, our team decided to focus on the first question that you see here. Specifically, how is this life-saving therapy being utilized in clinical practice? So we looked at this in different patient populations and using different databases. This particular analysis was done using the Advancent database, which was a heart failure focused database. And we looked for patients with a prior myocardial infarction and an ejection fraction of 35% or less. And much to our surprise, we found that only 41% of eligible white patients had a primary prevention ICD, and only 30% of eligible black patients had a primary prevention ICD. So we really got concerned about these findings and decided to look at gender disparities using the Medicare claims database. And so we conducted this analysis to look for primary prevention ICDs, secondary prevention ICDs, and see how women compare with men. And much to our surprise and disappointment, we actually found that men were 3 times more likely to have received an ICD for a primary prevention indication, and about 2.5 times more likely than women to have received a secondary prevention ICD. And so we decided to probe further, and we looked at the use of primary prevention ICDs in the AHA Get With The Guidelines database. In this particular analysis, we looked for patients who were hospitalized with heart failure and an EF of less than or equal to 30%, and who were enrolled in the AHA Get With The Guidelines database between 2005 and 2007. And we tried to apply some exclusion criteria, some of which were related to the presence of contraindications. And we were surprised to find that only 35% of eligible patients had an ICD in place or an ICD planned. And when we looked at these important subgroups and we compared them with white men, we found that black men were 27% less likely to have a primary prevention ICD, white women were 38% less likely to have an ICD, and black women were 44% less likely to have a primary prevention ICDs. So these results were certainly concerning. And we decided that it is really important to try to understand why this underutilization exists and why do these disparities exist. And so in this particular project, we partnered with a research group at the University of Colorado in Denver and with the American College of Cardiology. And we surveyed members of the ACC who are also practicing cardiologists in this country. And we presented them with different case scenarios of patients who clearly needed a primary prevention ICD, and we varied the patient's age, the patient's gender, the patient's race, and we got responses from more than 1,200 physicians. And at least based on the responses to our survey, physicians were not less likely to recommend a primary prevention ICD to women or racial minorities, but they were significantly less likely to recommend or offer a primary prevention ICD to older patients. And then we decided to look at the Duke experience. We said, why don't we look for patients who were hospitalized at Duke between January and August of 2007 with heart failure, and we mandated that they should have had an EF of less than or equal to 30%. So we wanted to see what we're doing here at Duke. So we found that of the 542 potentially eligible patients identified, 224, that is 41%, did not have an ICD. And when we looked at those data, we found that female gender and increasing age were associated with a higher likelihood of not having an ICD. But then we decided to delve deeper into this issue, and we conducted a detailed chart review. And we found that of the 224 patients who did not have an ICD, 117 were ineligible. They had contraindications, either because of multiple comorbidities, limited life expectancy, active ongoing infection, and so on. We found that 38 patients actually were offered an ICD, but refused to get one. So that actually left us with only 69 patients, meaning 13% of the original 542 potentially eligible patients who did not have an ICD, and who there was no documentation in the chart that an ICD was actually even offered to those patients. But I tell you that these results may actually portray a best case scenario, and it is important to try to redo this study in other settings. And my colleague Brett Atwater actually did that within the VA system, where he actually looked at different heart failure therapies, evidence-based therapies, and looked at those patients who were not on those therapies. One of those therapies was actually the Implantable Cardioverter Defibrillator. And he found that a large number of patients who did not have these therapies, who were not receiving these therapies, actually had very acceptable contraindications to them. So this really highlights the need to look very carefully at contraindications when you talk about underutilization and disparities as well. And in this particular analysis, we decided that since the AHA Get With The Guidelines database is a quality improvement initiative, we really need to look and see if things have actually improved over time. You may recall that the initial analysis from the AHA Get With The Guidelines that I shared with you was actually done between 2005 and 2007. In this particular analysis, we extended the time frame to 2009. And we really wanted to see if the use of primary prevention ICDs has improved over time, and to look and see what has happened with those racial and gender disparities that we reported back in 2007. And we were pleased to see that the rate of use of primary prevention ICDs improved from 35% in 2005 to 42% in 2009. And then when we looked at the different subgroups that I mentioned to you earlier, we were very pleased to see that the use of primary prevention ICD has actually improved in all of these subgroups. And then, of course, it was natural to ask the next question, which is, well, did any subgroup improve at a greater rate than the other subgroups? And we found, which was really interesting, that it seems like Black patients seem to improve at a greater rate than white patients, such that this disparity, this gap in care seems to be closing. But that was not the case for women. So both women and men improved, and the disparity has persisted. And so we have actually made several recommendations regarding how we can improve the utilization of primary prevention ICDs and how we can address disparities. And one major attempt that our group has made is really by forming the Sudden Cardiac Arrest Thought Leadership Alliance. This alliance is composed of several people from academia with expertise in sudden cardiac arrest and in ICDs and other therapies for prevention of sudden death, as well as representatives of different professional societies and different stakeholders. And we had a couple of think tank meetings, and we've published several papers. But really, the intent is to brainstorm about ways by which we can address disparities, how we can improve the utilization of primary prevention ICDs. So we now are developing educational materials, targeting the public, patients, healthcare providers, and we have several other projects that are ongoing. This paper was actually led by Zubin, who did an excellent job writing it. And then my colleague Kevin Thomas actually did this pilot study called the VIVID pilot study, where he really wanted to see if a video intervention would increase patient knowledge about ICDs and would decrease decisional conflict regarding ICDs. And one other question that is of great interest to us is whether racial concordance among patients who are being counseled about an ICD and the video participants would result in lower decisional conflict and greater patient acceptance of ICD implantation. This was a pilot study of only close to 60 patients. It was mostly done to prove feasibility. The results will be presented by Kevin at the Heart Rhythm Society meeting coming up in May. And I understand that the paper has been accepted for publication, but the real thing is to be able to launch a larger multi-center clinical trial that will have the power to address these questions more definitively. So I tell you that all this message about underutilization of ICDs and these disparities has really resonated with the medical community. People got very excited about it. They were sending us notes, congratulating us, cheering us on. I personally use this example because I'm a big fan of Roger Federer, but this other example here, I'm sure appeals to most people in the audience, me included, so everybody was happy about that message. But we as a group decided that we also need to look at overutilization of ICDs, because we truly believe that if people are overutilizing this therapy, that's an issue too, and it needs to be addressed. And this is what led us to do this study here titled Non-Evidence-Based ICD Implantations in the US, where we used the National ICD Registry and we examined non-evidence-based ICD use. Now, I do want to highlight non-evidence-based here, because this project was not intended to be non-guideline-based or non-CMS guideline-based. Really, we were interested in the pure evidence from the randomized clinical trials. So how did we define non-evidence-based? We defined it as patients who just had an acute MI, and many of you know that both IRIS and Dynamite, well-done randomized clinical trials, showed no benefit from primary prevention ICDs in patients who just had an acute myocardial infarction. We defined it as patients who just had CABG, and many of you are aware of the CABG patch trial that showed no benefit from ICDs. And we also defined it as people with a new onset of heart failure, as well as patients with class 4 heart failure symptoms, where, as many of you know, really there's no evidence that primary prevention ICDs are beneficial in those subgroups of patients. And so we found that close to 23% of ICD implants did not meet evidence-based criteria for implantation based on the definitions that we used. And of course, I would be the first person to say that we should allow for clinical judgment and that some of these non-evidence-based implants may have been acceptable. But what we were able to highlight is that at some of these centers that we looked at, the rate of use of non-evidence-based ICDs approached 50, 55, 60%. So I think there is a quality of care issue there that needs to be addressed. And then when we looked at the rate of use of non-evidence-based ICDs over time, we found no significant change. And when we looked at their in-hospital outcomes, we found worse outcomes in those patients who received non-evidence-based ICDs, even after we adjusted for potential confounders and even after we excluded patients with class 4 heart failure symptoms. Now, of course, this message certainly did not resonate with the medical community, and it left many people frustrated, disappointed, sad, and even crying. So why did we do this? I think because it is important that we provide the best care to our patients, and I truly believe that most of us strive to do so. But it is also important to note the changing healthcare environment that we're living in today. Those of you who have had a chance to review some aspects of the healthcare reform plan would appreciate that the plan actually really emphasizes several quality improvement initiatives. So these upcoming opportunities, at least I view them as opportunities, some people may view them as challenges, include quality measurement, performance measures, what have you, public reporting, demand for transparency, and believe it or not, the healthcare reform plan specifically mentions appropriate use of cardiovascular care. So this is definitely key. And so what we're seeing today is more and more emphasis being placed on performance measures. And now people participate in this. It is voluntary and it's confidential. But it's expected that this year, this information that has been confidential will become public knowledge. People can just check your outcomes by going on this Physician Compare website. And it is expected that in 2015, just 2 years from now, Medicare reimbursement will be adjusted based on documented quality outcomes. And this voluntary reporting that we're participating in now is expected to become mandatory in 2015. And so why bother? When performance is measured, performance improves. When performance is measured and reported back, the rate of improvement accelerates. And that's true of anything. Not just overutilization, but also underutilization of therapies, anything that's related to patient care. And so now to move on to the other gap in knowledge about ICDs, do the results of the pivotal randomized clinical trials apply to patients seen in clinical practice? Our group has addressed that as well in this publication that came out earlier this year, really comparing patients receiving a primary prevention ICD in the National ICD Registry and comparing them with patients who were enrolled in MADE-2 and in SCEDHEFT. So as you can imagine, when we compared these patients, not to anyone's surprise, patients who were enrolled in the clinical trials were younger and they were relatively healthier. And that's not a surprise. And so to be able to compare their outcomes, we had to do propensity score matching to make these groups comparable. And then we looked at their outcomes. And we were very pleased to see that patients who received an ICD in the National ICD Registry had a survival pattern that was very similar to patients who received an ICD in the MADE-2 trial. And the survival of those two groups was significantly better than the survival of patients who received medical therapy alone in MADE-2. And when we repeated the same analysis in SCEDHEFT, we also found that patients who received an ICD in the National ICD Registry for a SCEDHEFT indication had a similar survival to patients who received an ICD in SCEDHEFT, and their survival was certainly better compared with people who received placebo in SCEDHEFT. So these results are very encouraging, but some people actually have asked us, well, you used propensity score matching, so you made the groups very similar, so what did you really address? What I think we truly addressed is, as you know, in clinical trials, patients get the best care. They get monitored very closely. Their follow-up is amazing. And so the fact that we were able to show that even in clinical practice, when the quality of care is not likely to be as good, and the adequacy of monitoring is not as good, that ICDs are associated with improved outcomes, I think that is a good message to send out. So what about the benefit of ICD therapy? Is it durable beyond the limited follow-up period of the clinical trials? As I mentioned to you, the median follow-up in SCEDHEFT was 45 months. Mean follow-up in MEDA2 was 20 months. So I think it really is important to look at this. Unfortunately, we've only looked at this in the realm of observational data. And what I mean by that is that both the MEDA2 investigators and the SCEDHEFT investigators have now conducted long-term studies. But the longer term outcomes here that they captured beyond the follow-up period of the clinical trials is purely observational. But clearly the MEDA2 investigators showed that ICDs were associated with a 37% relative risk reduction in 80-year mortality. This paper has been published. The 10-year follow-up data from SCEDHEFT were presented at the Heart Rhythm Society meeting back in May of this past year, but the actual data have not been published. The paper has not been published. But the results were also very favorable, showing that even up to 10 years, people who received an ICD seemed to have improved survival. So now we move on to talk about how do we optimize the safety of ICDs and leads. I think there are a lot of things that we could do to do that, but one of the things that you've heard about is the subcutaneous ICD. And I tell you, as someone who has really reviewed these data very carefully, I think they're definitely promising and the results are encouraging. But I personally don't think that we are where we need to be to change practice. And what do I mean by that? If you look at the one publication that appeared in the New England Journal of Medicine in 2010, that actually had only 188 patients enrolled in 4 different trials. And yes, the results were promising, but that's such a small number of patients. And their biggest focus was efficacy of defibrillation, safety. We didn't really see any hard endpoints. And some of you may be aware that a prospective cohort study was presented at the Heart Rhythm Society in May of 2012. Again, they presented data on 330 patients, very promising, but mostly looking at the efficacy of shocks and does it sense arrhythmia well and things like that. That's all good, but I still think that there is a lot of need to do randomized clinical trials comparing the subcutaneous ICD with the transvenous ICD and looking at hard endpoints and over longer follow-up periods. So I personally think that this is promising, but we're certainly not at a point where we need to be changing practice. But there's a lot of research that needs to be done in this area that I'm very excited about. And then we move on to the other gaps that I listed earlier. Can we improve risk stratification of patients for sudden cardiac death beyond the ejection fraction? And as someone who has done some work in this area, I couldn't be more disappointed because every test we've looked at has really not withstood the test of time and has not met our expectations. I think there is some thinking that maybe we need a set of tests or maybe some sort of model, but we've seen several models like the Seattle heart failure model, but those need to be really user-friendly. They need to be useful clinically. And I think at this point, what I see is really too complicated to really help. But why do we use the ejection fraction? It's because the randomized clinical trials use the ejection fraction as the main entry criterion. And as such, I see us using the ejection fraction for now until we get more data. What about the cost effectiveness of ICD therapy? I'm sure many of you know that Dan Mark, our colleague, led this wonderful project based on the SCEDHEFT data looking at the cost effectiveness of ICDs and really showed that it was pretty favorable in the SCEDHEFT data. And then when we actually did this cost effectiveness analysis of ICDs in patients 65 years of age or older, again, it seemed to be favorable. So at least so far, the indicators look very promising. Now, how do shocks affect survival and quality of life? This is an issue that emerged in 2008 based on this publication from the SCADHEFT trial looking at the association between shocks, both appropriate and inappropriate, and outcomes, mostly survival. And they actually showed a significant increase in the risk of mortality with appropriate and inappropriate shocks. So this actually has fueled a big debate in the EP community where people are asking, do shocks directly affect things and worsen survival, or is the fact that somebody had a shock, is that a marker that their underlying cardiovascular disease is progressing and that's why they have worse outcomes? So that's still an ongoing debate. As for the quality of life and how shocks affect quality of life, from the SCADHEFT data, clearly there was some evidence that shocks affect quality of life. But what was interesting is the following. A lot of these differences and these trends were eliminated when the window between the ICD shock and subsequent assessment of quality of life was extended to a year. So at least it was good to see that this is not something that really persists for the lifetime of the patient. And then finally, how do we reduce the risk of inappropriate ICD shocks? I'm sure many of you are aware of the MADE IT RIT trial that was published in the New England Journal of Medicine last year. Dr. Daubert was involved in this. We were actually assigned for it. This trial basically looked at conventional programming of the ICD and compared it with two investigational programming, high rate and duration delay. Here's how they defined those. Duration delay is that the device would wait for 60 seconds if the arrhythmia is at 170 to 199 beats per minute, would wait for 12 seconds if the arrhythmia was at 200 to 249 beats per minute, 2.5 seconds if the arrhythmia was at 250 beats per minute or faster, high rate 2.5 second delay before therapy delivered at a detection rate of 200 beats per minute or greater. And we were very happy actually to see some of these interesting results showing that either one of these investigational arms had better outcomes than conventional programming, with a significantly lower risk of inappropriate ICD shocks displayed here, but also very interestingly, a decrease in all-cause mortality that was statistically significant for the high rate group and just with a trend towards statistical significance with a p-value of 0.06 for the duration delay group. So certainly interesting results. Remember, MADE IT RIT was done in a primary prevention population, so several people within the AP community don't feel comfortable to extrapolate these findings to the secondary prevention subgroup of patients. So clearly we've done a lot, but there's still a lot more to do. So where are we going? I think understanding the effectiveness of ICD therapy in patient subgroups not included or not well represented in clinical trials is going to be really important. Maximizing product reliability and minimizing recalls and advisories is a top priority for all of us. Comparing single versus dual chamber ICDs, conducting randomized clinical trials of subcutaneous ICDs powered for hard endpoints. That's really key. I think as a medical community, we need to demand that. And improving risk stratification for sudden cardiac death beyond the ejection fraction. And these bullet points that are bold-faced and underlined are things that our team is currently working on. In addition to understanding the relationship between ICD shocks and survival, improving utilization and reducing disparities, which is something that we have been working on, and of course improving the outcomes of patients with an ICD. I think this last one here is really key. And this is the main reason why we decided to launch the Calypso pilot trial that you may have heard about. These are patients who have ischemic heart disease, who have an ICD for a primary prevention indication or a secondary prevention indication, and then end up receiving an ICD shock or at least 3 bursts of antitachycardia pacing for ventricular tachycardia, and you rule out reversible causes. These patients become eligible and then they get randomized in a 1-to-1 ratio to a strategy of pharmacologic therapy versus a strategy of early VT catheter ablation. And all of these patients are being followed for 6 months. And this is a feasibility study with just 50 patients. We are looking at some secondary endpoints, but the hope is that if we can prove feasibility, that we will be able to launch a larger multi-center randomized clinical trial that is powered enough to look at some important hard endpoints. So we're very excited about this. And then another thing that we have done in looking at improving the outcomes of patients with an ICD is really looking at the follow-up of these patients. We use the Medicare claims database to conduct this particular analysis that was just published a couple of weeks ago, where we looked at all patients with devices, but definitely patients with ICDs was a big component of this cohort. And we found that the follow-up of these patients is not in line with the recommendations that were made by the experts in an expert consensus statement. Making recommendations that patients, with a pacemaker need to be seen within the first 12 weeks, and then they need to have adequate follow-up up to 12 months, and then patients with ICDs, again, first follow-up visit within 12 weeks, and then follow-up every 3 to 6 months. And we found so that what we're seeing in clinical practice is not in line with these recommendations, but when we looked at trends over time, things are improving. And maybe, most likely this is multifactorial, but I think that introducing remote monitoring has really helped improve the follow-up of some of these patients. So this is definitely interesting. In a follow-up paper that Paul Hess is actually leading, we are looking to see if you follow these recommendations, is that associated with improved patient outcomes? So it's very interesting results. I can disclose them now. So to conclude, I can say that there is clearly compelling and convincing evidence that ICD therapy improves survival in different patient populations. This is why underutilization and disparities in the use of this life-saving therapy are major problems that need to be addressed. But I also believe that we need to make greater efforts to focus on appropriate use of ICDs, because I truly believe, given the cost of this therapy, how invasive it is, that only patients who could potentially benefit from ICDs should receive them. The interesting thing is that there still are many remaining uncertainties that need to be addressed by future research. And I tell you that I'm very excited about the future based on all these uncertainties that we still have to address. But when I reflect back on my career journey, I can tell you that it's been wonderful. I've enjoyed every bit of it, and what has made it much more worthwhile is really the people that I've had the opportunity to work with. I can't thank them enough, the 3 top people here who have been mentors for me, and really many people within Duke and outside Duke, and many people on the clinical side of things, and my advisees that have kept me going. It's been a wonderful experience for me, as well as my administrative assistant, and really all the people who have contributed to the work that we have done. I'm very grateful. And certainly to my family, who has been very supportive of me. So I couldn't really find a better quotation to end my presentation with, other than this one here. In normal life, we hardly realize how much more we receive than we give. And life cannot be rich without such gratitude. It is so easy to overestimate the importance of our own achievements compared with what we owe to the help of others. So thank you very much.